Good morning, afternoon, evening, depending on where you are, and welcome to this keynote lecture today by Neel Ahuja. My name is Reti Gobak, and I'm a postdoctoral researcher at the Center for Women's and Gender Research at the University of Bergen. And yeah, it's with great pleasure that I would like to introduce you to Neel Ahuja, who is currently a visiting professor at the University of Maryland with appointments in the American Studies Department, as well as the Harriet Tubman Department of Women, Gender, and Sexuality Studies. And Neel has a background in transnational literary and cultural studies from the University of California in San Diego, and gender studies from Northwestern University, where he also worked as an organizer in international labor and animal advocacy campaigns. Neel's research explores the relationship of the body to the geopolitical, environmental, and public health contexts of colonial governance, warfare, and security. Neel is the author of two books. The first one, Bioinsecurities, Disease Interventions, Empire, and the Government of Species, came out in 2016. And last year, 2021, his book, Planetary Specters, Race, Migration, and Climate Change in the 21st Century was published. He has written a variety of essays on the connections of race and colonialism to the fields of disability studies and animal studies. And he's currently working on two research areas, one exploring the race and species politics of COVID-19, and another analyzing United States counterterrorism, incarceration, rendition, and interrogation practices. So Neel, the floor is yours. And we will hear more about your new work, especially how it is growing out of your recent book on planetary specters. So warm welcome.
Thank you.
Sorry, I just remembered. Yes, I'm supposed to say that we would like you to post questions in the chat box to save time at the end, so that we give enough space for Neel, but also leave some time for answers from Neel. So please feel free to use the chat box while Neel is presenting. So sorry about that. And now over to you, Neel.
Thank you so much. I really appreciate everything you've done, Reti, to make my virtual visit possible. And thanks to all of the organizers of the Summer Institute, as well as to all of you in the audience for joining us today. I'm really excited to share some recent work that I've been doing with you. And some of the context for how I became interested in thinking about new logics of race during the COVID-19 pandemic has to do with the fact that I was writing this earlier book, Planetary Specters, which is about climate change and migration. And then suddenly, towards the end of finishing that book, the pandemic lockdowns began. And the migration patterns that I was studying for my book were suddenly shifting very rapidly. I wouldn't say that they came to a halt. People were still migrating, but they were doing so with an added layer of state scrutiny. And the kind of focus of state concerns about racial security shifted in certain ways to both border policing that was energized through new public health emergency measures that would allow more migrants to be kept out of state borders and prevented from making asylum claims on the one hand. And then second of all, internally to nation states, there was heightened awareness of the ways that racial disparities were playing out on a more localized level. So weirdly, at this moment when I was finishing up a book on transnational migration that looks at countries like Syria and Bangladesh and is trying to think about how climate processes like desertification and floods and weather disasters are affecting or contributing to longer-term international inequalities that generate migration. There was this kind of sudden moment where in terms of certain emergency governmental logics, race was starting to be looked at separately on a transnational scale from a very localized scale that public health officials and epidemiologists were looking at it. So part of what I'm going to do today is try to trace the early steps that public health researchers have taken to think about race as central to understanding the COVID-19 pandemic. And I want to emphasize that although examples and research studies that I'm pulling from for what I talk about today, a lot of them refer to the United States, this research that I'm doing is not centrally about the United States. That actually a lot of the dynamics that we're looking at when we talk about COVID-19 inequalities are inequalities that are emerging across different nation states. But the particular epidemiology and the theories of race that public health researchers are generating, that I find both in some ways needing kind of supplementation from critical race theories, and on the other hand, really generative and offering us new concepts and theories. Both of those things are happening at the same time, and they're coming by and large through studies that I've read on the United States. So much of what I'll talk about in the next few minutes, I'm only going to talk for about 20 minutes more, and then I'm hoping we can have some discussion, will be focused on epidemiological studies of COVID-19 over the last 2 years that have focused on social inequalities and in particular racial disparities in COVID-19 outcomes. That means both infection rates and death rates. I'm hoping that we can have a conversation about this at the end, but I'm going to actually read from my notes here starting now. So let me also launch the PowerPoint presentation, and you can see that, right? If there's something wrong, let me know. Okay, so herd racialization, pandemic inequality, and the remaking of population. The COVID-19 pandemic has been the context for public health institutions, epidemiologists, and a range of social scientists to make a public case for an idea concisely stated by the American Medical Association in November of 2020, quote, "Racism is a threat to public health." While a range of activists and medical historians have long noted inequalities of access and outcomes for patients, as well as exploitative conditions for research subjects based on race, class, gender, sexuality, nationality, and disability, such a statement by the American Medical Association reflects a shift in public discourse for an organization that has historically worked to entrench such inequalities through its advocacy against universal health care for the United States and through an elitist approach to medical training that shrinks the number of available health professionals. In the wake of the murder of George Floyd by Minneapolis police officer Derek Chauvin and the summer of Black Lives Matter protests that followed in the United States, the AMA board and other health officials made public statements about the health consequences of racism, the consequences of rising xenophobia, and discrimination against Black patients and doctors. The Centers for Disease Control in the United States clarified that not only is racism an interpersonal relation, it is a structural one, which requires addressing a full range of social determinants of health. The World Health Organization convened an expert panel in March 2021 to address the relationship between health inequalities and COVID-19 outcomes and what they called discrimination based on race and ethnicity. At the same time, both media discourse and scientific research on COVID-19 publicly highlighted inequalities in viral exposure, case rates, hospitalization rates, death rates, vaccine uptake, and other indicators of social vulnerability. Recognition of widespread inequalities in COVID-19 outcomes also led social scientists and epidemiologists to set forth interdisciplinary analyses of COVID-19 as they relate to social phenomena ranging from housing segregation to occupational health dangers, to transportation inequalities for different segments of a given society. And I'm just going to show you here that there's one study that I find really useful on this. This is focused on the city of Chicago in the United States. It's called COVID-19 Race and Redlining. And it looked through the early pandemic data in the city of Chicago through June of 2020, finding that Black residents in the city comprised 35% of deaths, which is significantly above their proportion of the population. a kind of 1/3 increase in deaths overall for that subgroup. And I'm just going to quickly go through some of the findings of this study. One of the quotes, it says, "Far from being determined by genetic and biological factors, such vulnerability can be linked to socioeconomic status and household composition as the likely channels through which the legacy of the past manifests itself." That past, which is redlining, involves the segregation of neighborhoods through different kind of financial tools that allowed mortgages to be denied to Black residents in Chicago. Now, that study looked at COVID-19 mortality data, and it compared it to the 1935 redlining maps, which demonstrated housing segregation in Chicago, and they overlap almost 1-to-1. So health comorbidities for Black Chicagoans like diabetes and heart disease were already higher in these regions that experienced kind of negative housing segregation. And that led to significant impacts for COVID-affected populations. The authors also write, quote, "The fact remains that the evolution of the epidemiological curve reveals for the US an extraordinary degree of racial and ethnic segregation, with different groups displaying profoundly distinct patterns even in the timing of their exposure to the epidemic." I want us to think for a moment about this issue of the timing of the pandemic. And one of the things I'm going to address in the talk today is the way that differently racialized groups, according to the epidemiological literature, are experiencing a different timing of what happens with COVID-19 spread. This is one of the key findings in the literature, and this is only one study that points to it. So, sorry, just one moment here. So although innovative work like the redlining study that I just showed you has moved towards producing more contextual knowledge of race in particular localities, industries, and legal contexts related to public health, much of the national level data that we get so far suffers from certain data problems that flatten the complexity of racial identity and fail to capture experiences of certain groups, such as indigenous groups and multiracial individuals. Based on large data sets collected by governmental health agencies, US data on this tends toward what we call a 4 food groups view of race, that there are these 4 major categories of different races in the United States, and you can discretely kind of group them separately. So those groups, are generally characterized as Black, Asian American, Latinx, or Hispanic, and indigenous groups. And often indigenous groups are left out of the data entirely due to small samples. So this repeats a larger problem that has long existed in social science and other health and medical related data for indigenous peoples. Now, data on these disparities has often been helpful in articulating certain stark differences on a mass scale. So things that we see relative population pandemic. Although many of the media reports highlighted inequality facing Black and Latinx groups, the more comprehensive and critical data sets showed from an early stage that there were also unequal outcomes for Indigenous Americans and Asian Americans affected by the virus. Recent published data from the Centers for Disease Control in the US puts American Indian risks of hospitalization rates at triple those of whites, and the death rate as the highest among all groups in the United States. So let me return to the slideshow and then when some data showed that Asian Americans experienced case and hospitalization rates similar to or lower than whites, breakdowns of the Asian American demographic in the New York region showed a more complex picture, with high case and hospitalization rates among South Asian Americans and Chinese Americans displaying the highest death rates of all non-white groups. So the fact that when you are able to disaggregate different subsets of Asian American populations, you see huge spikes for certain negative outcomes in certain categories, but when they're all generalized and lumped together, you no longer see the discrepancy. Such research on Asian Americans was also confirmed in the UK context as well, where Black and South Asian groups fared worse in terms of cases, hospitalizations, and deaths. And data from Brazil demonstrates even starker inequality, with a study from Maranhão showing that Black and brown Brazilians had over twice the seroprevalence of COVID-19 than white Brazilians. Now, this study also repeats some of the problems with racial categorization. It just uses three categories: white, brown, and Black, and it excludes indigeneity as a category for measure. At the very least, though, these studies as a whole suggest that more detailed breakdown studies incorporating patient and community narratives will be crucial in obtaining a clearer picture of how racialized groups have experienced a range of pandemic impacts that are dependent on local conditions. And it's my hope that, what I'm going to be talking about today indicates that there's possibilities for doing future research that is more locally responsive, but is also attentive to the texture of experiences people face when they're caring for relatives with COVID-19, when they are infected by COVID-19, and when they put in labor in order to help recover as individuals and as communities. Research on racial difference and disparity in COVID-19 dynamics and outcomes remains in a nascent stage. Looking at the early work embedding notions of racial difference into constructions of risk helps us to make sense how the move towards recognizing racial difference, such as the moves that have been made by the American Medical Association and the CDC, help us begin to recognize racial differences within health and medicine and how they contribute to emerging forms of racial knowledge and governance. So I'm going to be arguing in the next few minutes that while such research tends to suffer from the abstraction of large racial groups and quantitative data, it also takes initial steps towards reframing mass concepts in epidemiology. And today I'm going to look specifically at herd immunity as the main concept that epidemiological data on race is really helping to think in interesting ways. So I'm going to try to demonstrate that this data is not just showing disparities in outcomes, not only disparities in things like death rates and hospitalizations, but also unequal burdens of immunological labor. So two recent articles that work with race in large COVID-19 data sets demonstrate both the potentials and pitfalls of centering race along these lines. The first study, Trajectories of COVID-19 Vaccine Intentions Among U.S. Adults, the Role of Race and Ethnicity, was published in SSM Population Health by three sociologists, Michael Nino, Brittany Hearn, and Tianji Kai, in February of 2021. Utilizing data from the Understanding America study, the authors make two lines of argument. One, they track the declining enthusiasm for vaccination among all racial groups in the early phase of vaccine rollout. And two, they argue that Black Americans in particular experience significantly lower vaccine enthusiasm than other racial groups in the United States, concluding that a history of anti-Black medical neglect and violence likely results in distrust of medical authorities. In turn, the authors argue that intervention strategies should turn away from stigmatizing vaccine hesitancy and more directly address the histories of inequality that underlie mistrust of doctors and public health practitioners. The second article, Modeling the Impact of Racial and Ethnic Disparities on COVID-19 Epidemic Dynamics, was published in the open access journal eLife by public health researchers Kevin Ma, Tigist Menkir, Stephen Kissler, Jonathan Grant, and Mark Lipsitch in May of 2021. And this image is of the preprint version of that, but it's now actually been published. Analyzing data across New York City and the Long Island area of New York City in particular, the authors argue that the calculation of herd immunity, and specifically the herd immunity threshold, which is an important public health data point, masks deep inequalities in case rates. These inequalities don't just reflect different life outcomes for people who contract COVID, but a different course for the epidemic as a whole, and a different experience of time for racialized minorities. As higher risk racial groups experience case rates that balloon to as high as 4 times the average, these groups bear the disease burden that ultimately produces enough post-infection immunity to allow a larger population-wide decline from peak infections. So just to illustrate here, what we normally see in the pandemic curve, that we've seen many of these graphs in media over the course of the pandemic, is that there's a steep rise in cases as the virus spreads, and then there's a point at which it peaks and declines. And that point reflects the moment at which there's enough widely distributed immunity to the disease. In the early part of the pandemic, this was solely due to people's exposure to the disease. And in later stages, it was also combined with vaccination effects. That peak, is the point at which you reach a point where there's enough widely distributed protection in the national sort of immune system to produce a decline in cases. However, when these public health researchers look at the data, what they find is that the herd immunity threshold is actually heterogeneous. That if you assume that the population as a whole is the site for measuring the herd immunity threshold, then it's going to produce a different kind of graphic and projection of risk than if you separate out higher risk groups and look at the data separately. So studies such as these two reflect some limitations of the data collected from the 4 food groups' racial categories, as they fail to adequately capture American Indian or mixed race disease dynamics or to disaggregate complex intergroup differences. However, at the same time, they each point to the ways that COVID-19 has not only been unequal in direct costs for people of color in the United States, but also in the immunological burdens it places on those minoritized populations to move the infection curve from pandemic to endemic. So the Ma et al. Study displays a graph showing that Latinx patients on Long Island bore 4 times the disease burden of whites, and Black patients bore twice the burden. Their cases collectively contribute to the population as a whole more rapidly reaching the herd immunity threshold. If people of color are significantly overrepresented among the number of people infected early in the pandemic, then they differentially contribute to the population level immunity through their own experience of illness and the concomitant higher death rate that occurs within their community. The authors put it this way: incidence rate ratios are elevated initially in high contact groups relative to non-Hispanic whites, but this trend reverses after the epidemic has peaked and overall incidence is decreasing, a consequence of the fact that a majority of individuals have already become infected. One consequence of this reframing of the herd immunity threshold as heterogeneous based on race is that the HIT infection threshold is different for different groups. The authors note that in Long Island, in New York again, the racial differences at the peak of the first surge in 2020 were especially stark. Quote, "The burden of infection fell disproportionately on minority populations. In a model fit to Long Island serosurvey and census data, 81% of Hispanics or Latinos were infected when the HIT was reached, compared to 34% of non-Hispanic whites. Our findings, which are meant to be illustrative and not best estimates, demonstrate how racial and ethnic disparities can impact epidemic trajectories and result in unequal distributions of infection." This conclusion sheds light on the 80% herd immunity threshold figure that is often reported in media, meaning that once 80% of the people have either contracted COVID or have been vaccinated, at that point you'll see a steep decline. Although the higher infectiousness of current variants would have resulted in a different curve than what was being discussed in 2020 in New York, the vast disparity means that Latinx residents bear a starkly disproportionate burden of what I would call immune labor, which consists of doing the work of undergoing infection in one's body, distributing care labor within and beyond the household for people who have COVID-19, and developing immune defenses in the body through recovery, which then contribute to the population immunity. White residents are in turn likely to misapprehend the cause of their relatively higher rate of susceptibility at the peak of infections, while they unequally benefit from the ensuing decline in cases. Racially unequal immune labor thus plays a central role in the potential for dubious political manipulation of health data. The premature declaration of endemic status for COVID-19 in the United States, pronounced by right-wing politicians, which echoed what happened in several other countries like Brazil in early 2022, reveals that the politicized desire for pre-pandemic capitalist normalcy is enabled in part by the shadow immunological labor of racialized minorities. The relative burden of disease for whites during spikes in infections is minimized in this public discourse, and such a situation can minimize the spectacular effects of contagion to burnish reactionary arguments about evolutionary fitness and calls for an early end to public health protections. So the early history of COVID-19 seems to involve a situation in which racialized minorities bear the compound burdens of early infection and the labors that are required as a result, and state obstruction of workable health interventions. If we track this observation forward to consider the herd immunity threshold after the introduction of vaccines, we can restate the thesis like this. A combination of a higher rate of infection and a lower level of vaccination means that communities of color bear unequal care burdens and disease burdens due to a combination of higher exposure and compromised access to healthcare. For Nino, Hearn, and Kai, this occurs on the level of vaccine uptake as well. And for Black Americans, there's a need to overcome an ingrained distrust of the system marked by a history of experimentation and apartheid. The authors thus argue that, quote, medical and governmental institutions must begin to publicly acknowledge and address how racist structures have historically and presently fostered deep distrust among Black Americans. The very concept of herd immunity and the associated herd immunity threshold reflect certain eugenic legacies of the idea of population that inflected early 20th century colonial epidemiology as research on immunity to measles and other infectious diseases moved from the agricultural to medical domain. It's one of the reasons that the term herd is being used to apply to humans here. It's because the origin of this concept is in agriculture. Although my brief discussion of the racialization of herd immunity has not to this point focused on the gendered and animalized notions of reproduction evident in the long 20th century colonial history of herd immunity as a concept, such population-level thinking about viruses and vulnerability reflects a history of racialization of disease vulnerability that has long been embedded in US public health and the public health systems of other countries. It is necessary for scholars of race, gender, and public health to acknowledge these racial disparities in health outcomes, but also to not take them as the endpoint for our analysis of race and COVID-19, since they reveal that the racial regimes of colonialism are a broader structure, not isolated events, and not something that's in the past. The immune labors of groups experiencing racial and class marginalization, and I would add caste marginalization as well, literally construct the immunities of the speculated transition from pandemic to endemic COVID-19, and as such, they reflect the ongoing colonialization of public health efforts to embed national defense in the body itself. That's basically my argument for today, and I want to leave it there so that we have a little bit of time to discuss. But thanks for listening, and maybe we can find ways of chatting about this. I know that if you put something into the chat, Reddy might help us get started with the conversation. So thanks.
Yes, thank you so much, Neel, for this wonderful presentation that really complicated in very nuanced ways the way in which the racial inequities emerged during the COVID-19 pandemic. And yes, as Neel pointed out, feel free to use the chat box if you have any questions. Or also just raise your hand, that's fine too. And while people are thinking, I guess, yeah, I could start with a question. Towards the end, you were mentioning the gender dimension around these issues as well, which you didn't really get to talk about this that much. So I was wondering if maybe you wanted to say more about and also you mentioned gendered and animalized dimensions to this, in particular to the herds metaphor and all of that, and also this great concept of immune labor, which kind of made me think about the potential gender dimensions of that as well, if we think of the genderedness of care work and all of that. So if you would like to perhaps open up the gender dimension a bit more.
Yes, of course. I realized that because I was looking at very specific epidemiological studies and concepts, I was looking at how race is reconceptualized. And I'll just let you know that the math that is involved in these studies is so complicated. There's formulas for how to determine racialized groups, heterogeneous herd immunity thresholds. And so, this is a very kind of technical set of studies that I didn't really bring that into, because this is a broader interdisciplinary audience. So, of course, when we're talking about racialized groups and when we're talking about unequal health outcomes, these are things that involve gender in very central ways. So there's a very large literature in public health and medical sociology that looks at gender differences and very stark kind of inequalities and poor treatment of women by doctors in clinical encounters, for example, and then also the complex ways in which additional pressures that are faced by people who are either women or who are not conforming to the binary gender system, whether they're trans or non-binary, face particular challenges that have to do with socially reproduced risk. Reddy, you gleaned that one of the main ways that this emerges in COVID inequalities has to do with care labor and has to do with the changing ways that gender is incorporated into formal labor, right? So in a country like the United States, where labor has become increasingly feminized as in the transition to a service economy, women are often faced with the dual duty of doing the formal waged work and the care work. And so I think that, as more research is done in this area, and I think we're just at the early stages of how to think about this, there has to be a lot more attention and I think qualitative social science and humanistic studies of what has happened with care labor, who has done it, under what circumstances it's taken place. In the Latinx community that is identified in the main study I looked at, part of what we were dealing with was a population that had a significant undocumented element to it, and where a lot of both care work and formal work was being done by women. And so you can see that if the Latinx community reaches 81% infections at the point that whites in Long Island only have 34% infection rate, then there's an added layer of what's going on in terms of both formal work and care work in the community. And this reflects, I think the infection rate itself for Latinx people reflects the fact that they were doing vulnerable labor in the first place, that people were often housed in conditions where they were concentrated with other folks and couldn't get access to ventilation, and also where they were doing labor that had to be done in person that could not be made remote as easily. So the work-related vulnerabilities really require a feminist care work and feminist labor studies analysis in order to tease out all of the social complexity of this. So on the larger scale, what the data on the mass scale is reflecting is that these racialized kind of heterogeneous herd immunity thresholds that are being delineated in the data are then backed up by a kind of immunological labor that is highly gendered. And I can't make big conclusions about that because there isn't that in-depth research that's been done yet. This is very new. So those types of studies are absolutely what's needed next to understand how race does not happen in a vacuum, how race, gender, class, disability, nationality are all entwined, and how questions of indigeneity, caste also need to be brought into the conversation. So breaking those things down on a local level will take time, but I think you're absolutely right.
Yeah, absolutely. Thanks for this. I mean, the pandemic, shows, if anything, the necessity of intersectional approaches to these kinds of issues. So for sure. And we have two comments in the chat box as well. One from Jamie. Apart from race, how did entrenched economic inequalities as regards to Blacks and Hispanics contribute to access to vaccines and death during the pandemic?
Thank you, Yemi, for this question. These were very significant economic inequalities, and the effects were divergent. It wasn't the same for every person of color in the United States. So I think because of the same labor segmentation issues that I just talked about with the Latinx community, there was a slow uptake of vaccines for the Latinx community, but then over time, that flipped, and the Latinx community now, according to the national data in the United States, has one of the higher rates of vaccination. There were significant obstacles to access to vaccines and other interventions early in the pandemic that contributed to the fact that there were much higher case rates in the Latinx community than for whites. And in Long Island, it was 4 times the rate, right? In the African American community, the rates of vaccination have not increased in the same substantial way that they have for Latinx Americans. So the authors of that other study I was looking at really highlight the kind of longer term issues of medical and public health racism that have affected vaccine uptake. I think that there's a lot more to be said and debated about this issue because it was latched onto very quickly by public health officials that Black people in the United States needed to be targeted for kind of public health campaigning to get vaccinated, and that had its own, that kind of led to a certain repeating of a governmental discourse about the problem of Black noncompliance in the US, which mirrored many other pathologizing discourses that come from the government towards African Americans. And so I think that Black scholars looking at this issue, including the ones that I cited, have been asking for more complicated understandings of what's going on. And to actually use more interview-based data and to talk to people to understand what the thought process is behind all of this. So those are some of the things that I've seen in the literature about vaccination and inequality. But certainly, there's much more to be said there.
Thanks, Neel. So we have one more comment from Jagriti in the chat box. This could be related to casteism in India and tribal exclusion, where the marginalized people are forced to go to self-proclaimed doctors, or quacks to be precise. Do you have any comment on that?
Yeah, so I've read some of the work that's been done on India, and I'm also thinking about studies by people who look at the current configuration of health and science in India, thinking particularly of Banu Subramanian's book on holy science, that is trying to understand how at once India on a national level can be promoting itself as a kind of site of medical modernity. And you'll remember this with the vaccine production. The Modi administration was kind of promoting an image of India as the world's source for vaccines. It's not exactly how it played out in practice, but yes, it's one of the largest pharmaceutical manufacturing companies in the world, which has been written about at length by social scientists who look at international inequalities in the health and medical systems. Casteism was a very significant part of the inequalities that have been experienced in India. We know that the death rate has been significantly undercounted in India, the United States, and many other countries. The mass migrations that happened with the initial lockdown, especially among low caste workers, really significantly impacted those communities in terms of social economic vulnerability and in terms of actual disease spread. It was a horrific, and the ongoing effects of it are still horrific outcome. This issue of the use of allopathic Western medicine versus other forms of medicine is a more complicated one. It's one that where there's also Hindu nationalist elites that are promoting the quacks, and the idea that various cow-based fluids can be used to treat COVID. Now that hasn't become like the mainstream discourse, but it is something that's in the public discourse. So I do think that you know the question of these kind of non-allopathic remedies that are being proposed is something that came up in a lot of national contexts. It certainly has been happening in India, but also we saw in the United States, Trump promoting quack cures like vitamin D and the various toxic chemicals that people have been using in the United States to treat COVID or prevent COVID. So this is part of a larger kind of transnational configuration of right-wing populism targeting medical and public health expertise. So my first book was about public health imperialism and how these things get configured as politicized rather than technical interventions. So one of the things we're witnessing in the United States also is that now with the current configuration of the Supreme Court in the US, there is a very high chance that the actual public health authority to enforce things like vaccination is going to be taken away at some point over the next year. The main court case, Jacobson versus Massachusetts, which is an early 20th century precedent allowing individual states to have that kind of public health mandate, is something that Justice Scalia in the United States has indicated he wants to overturn. So the idea of critiques of medical expertise, we see them from the left. I mean, certainly the critical literature on race and public health is all about medical racism and a history of public health apartheid in the United States. But the kind of right-wing populism we see that attacks medical and public health expertise and proposes certain kinds of alternative medical or non-medical solutions to the crisis, it is part and parcel of a larger set of political contexts that, for which race is at the center and is at the heart of them. So masking and not reporting these heterogeneous effects of COVID-19 is one of the things that enables that kind of discourse. And I think that that's a lesson that needs to be examined in the US, but also in many other countries, including India.
Yes, and we have time for one last question before we close, from Desiree, who writes that to which extent what has been observed with COVID-19 in terms of race inequality is different from the other pandemics or natural disasters. What can be learned from this difference, if applicable? And she means other pandemics or disasters in the past.
Yeah, this is a really important question. It's a big question, so it is going to take time for us to answer this fully in a way that has to go beyond our session today. But, one of the things that happened early on is that among people who were critical of public health interventions, such as masking, to stop COVID-19 spread, part of what they did was to model things on the flu. And I think that the flu is one example of many that we can turn to think about prior public health histories and how this coronavirus is similar or different. I mean, I think that the similarities are there in terms of the fact that in many epidemic and pandemic contexts, the people who have the least resources in the society, who do not have access to good medical care, who are working in precarious jobs, who already have various forms of embodied vulnerability, tend to be the people who face the highest hospitalization and death rates. So that looks similar in the COVID-19 example to other health crises. There are very important differences. The communicability of this coronavirus is higher than many other viruses and mass pandemics that we've looked at in the past. And the political situation, the geopolitical situation, and will to work in a coordinated way across borders certainly doesn't look the way that it did even during the Cold War, when the United States and the Soviet Union had to kind of compete to show how well they were doing against smallpox. So many of our kind of strategies for dealing with a global pandemic actually come from that period, from the smallpox vaccination campaign, which was a huge global campaign to get people vaccinated. And that kind of strategy was nowhere to be seen in a coordinated way in the current response. So I think that there needs to be, you know, COVID-19 is coming on the heels of everything that we've learned about climate change. We're in a situation where we're seeing massive crises that are globally distributed, and there needs to be some kind of different political ordering for a real response that is attentive to the people who are most marginalized in various societies to not be left subjected to the worst health outcomes. That's a bigger project, but I do think that your point is showing that there's a big contrast today to when you look to what's happening now and to some other past moments where there was greater coordination and collaboration.
Thank you, Neel. That really reminds me of this comment by Arundhati Roy at I think quite early on in the epidemic, when she was saying that the COVID-19 pandemic can be viewed as a portal, or kind of like it's like a break between the past and the new world. So yeah, a gateway from one world to the next. So it seems like, yeah, much more work is ahead of us. Thank you so much again. This is all we had time for today. And
Thank you, Reddy,
yeah,
and thanks to everyone who was here.
thank you everyone for the questions, and for Neel for all the answers.